Thomas Baldrick here at ASCO 2015, Oncology.TV. Happy to be joined now by Dr. Martin Voss from Memorial Sloan Kettering. Thank you, sir, for taking a few minutes out of your ASCO conference.
My pleasure. Thanks, Thomas.
So let's talk about the DART study. Phase 2, 2 parts. Give us a background on this, would you?
Sure, pleasure. So this is a trial that we originally set up quite some time ago and that has gone through its first part and is presently enrolling patient on part 2, so I'll tell you a little bit about both. The background to all this is that, as you know, we have several agents that are FDA approved for the treatment of advanced kidney cancer using anti-angiogenic approaches. We know that key for the disease biology in kidney cancer is functional loss of VHL and a pro-angiogenic signal, and that's been exploited really by most of the standard agents that we have. For second-line therapy, one of the key drugs that is approved for kidney cancer is Axitinib, which is a pretty target-specific VEGFR2 TKI that, if you look at the phase 3 data on the AXIS trial, if you look at TKI pre-treated patients in the second line, has produced a response rate in the range of about 11% and a median PFS of somewhere short of 5 months. So certainly something to be improved upon. We are now on this trial, the DART study, combining Axitinib at standard dose with a novel medication called dalantercept. Dalantercept is a medication that's administered subcutaneously every 3 weeks, and it's an inhibitor of ALK1 signaling. The activin-like receptor kinase 1 pathway is a pathway that is also of critical importance to angiogenesis, but it's important for a later stage of blood vessel maturation. So VEGF, which we always talk about, is important for blood vessel induction early on. ALK1 is important for maturation, so the new blood vessels have to be maintained, stabilized, and that part we're interfering with dalantercept. So the biologic rationale here is to do a better job at anti-angiogenic therapy by blocking angiogenesis, which we know is key for kidney cancer biology from 2 different angles. And there are preclinical models that have shown that we do so more effectively, at least in vivo, if we combine these 2 approaches versus just doing one of them alone. The DART study has completed its first part, which was a dose-finding trial that we conducted and presented at ASCO this year. And we enrolled patients that had been pre-treated with at least 1 prior VEGF TKI, but up to 3 prior lines of therapy on part 1. And essentially we found 2 things. So for one, we found that the combination is well tolerated by patients. We had already known from the single agent phase 1 data for dalantercept that it has non-overlapping toxicities with VEGF TKI, and that's very important. If we combine 2 drugs that had the same toxicity profile, we'd see a lot more of that toxicity. So dalantercept does not cause hypertension on its own, it does not cause proteinuria, it does not cause hand-foot syndrome. On the phase 1 for dalantercept alone, we had seen fluid retention events and anemia as sort of the signal toxicity that were dose-defining. And on the combination, we actually saw that held out. So the rates of TKI-specific toxicities were what one might anticipate with Axitinib alone, and we did see the toxicity signal that we had known for dalantercept from its single-agent phase 1 study, and it was not exacerbated by the combination. So that was the key observation on part 1, is that we could combine the 2 safely at relevant dose levels tolerable to patients. And that's actually been a challenge for kidney cancer studies. We've done so many trials with different combinations that have always been hindered by the toxicity profiles we saw. So DART in that way certainly stands out. Efficacy signal on part 1 was promising. If we look at the part 1 data that we presented previously, then we reported an overall response rate across the different dose levels we tested of 25%, and we saw a median PFS of over 8 months. So if you put that into context with what I just told you about standard agents and pre-treated patients, it's certainly something that is of interest. It has to be put into perspective because it's a small cohort of patients. We treated less than 30 patients on the part 1 of the study, but it prompted phase 2, which is what we're undertaking right now. Part 2 opened several months ago, and at this point is open at about 40 centers throughout the United States. and is well into its accrual. This is now a randomized study, so we are now looking at patients who have had one and only one VEGF-directed therapy. They can have had an mTOR inhibitor, they can have had immunotherapy, but not more than one VEGF-directed agent, and they are randomized to receive Axitinib plus dalantercept at the dose level that we found most tolerable during part 1 versus Axitinib plus placebo. The benefit to patients is that everyone who goes on the trial, although it's a randomized trial, gets the standard agent at full dose. Patients can be dose escalated on their Axitinib as per label or per standard practice. And there's a 50-50% chance that patients are randomized to the investigational combination.
Very good. So when you get phase 2 or part 2 results, come back and see us, would you?
Absolutely, it'd be my pleasure.
Thanks, Dr. Voss. Appreciate
Absolutely.
your time.
Yeah, thank you.